Welcome everyone, it's Gary and I back again. Actually, I checked the last time we did a video was June 8th, so it's probably appropriate to introduce ourselves. I'm Gary McLeod, I'm President of the Medical Group. This is Dr. Gary Green, our infectious disease physician. So glad to be back with some updates.
So welcome back, Gary. I mean, you were on vacation, so I hope it was nice being back home in Europe.
Yeah, I was on an extended trip. I was in Europe where, I'll be honest, I never heard the word COVID for 3 weeks in Europe. I was in Switzerland where we could get a little hot weather, and then went to a cooler North Atlantic island called Scotland, who actually broke their all-time record yesterday at 94.6 degrees.
Wow.
So it's heating up over there.
Were people as grumpy in Europe as they are in the US right now?
No.
Yeah, not typically.
No. So back home, let's see what's happened over the last month. Gary, where are we at with the epidemiology?
So I wanted to show the map that we often show of the Sutter footprint. So this is the map, and I've actually labeled some important features here. As you can see to the left, the first bump is the alpha wave. The second bump there is the delta wave. The delta wave was more severe in cases, and the reason why the numbers are lower is because we started vaccinating during the alpha wave. So we really prevented a large delta wave. Then the Omicron wave came on in the first part of the year, and the first variant, the first subvariant of the Omicron variant was BA2.12.1. So in the BA2 subvariant of Omicron, there was a lot of cases, but not a lot of hospitalizations because it was so contagious and less severe. And then what's happened now is that we've seen an uptick of cases, and you can see the other subvariants, BA4 and BA5, have just layered on top of one another. So for us, it feels like one long surge, but it's been sub-surges and subvariants layering on top of one or the other. It's interesting that if you look at the blue shaded area, it seems like this wave is much smaller than the other waves. It's just because of testing. Yeah. So with the recent subvariants, people are testing at home, and so we're not counting those tests. And I think some people are even not even testing. So one person in the family gets it, they all get it. Not everyone's testing the family, they assume that this is the virus. So I really think that the waves, these subwaves of the new subvariants are just as high, if not higher. We know that the R0 number has gone up. The very first R0 number for the alpha strain was probably 2.5 to 3, then went 3 to 4, 5 to 7. The R0 number is about 15 to 16 now.
So that's the relative number of people that could be infected by an index case. So it's
right.
Much more contagious.
The higher the R0 number, the more contagious it is.
Yeah.
It's at the level of right between pertussis and measles.
Wow.
So it's extraordinarily contagious, and people are getting reinfected, even if you've been vaccinated. But the cases in the hospital have been very few and far between.
And it's interesting, the last few days we've seen this sudden drop, but I don't know if we can believe that. Because like you say, people aren't testing.
Right.
So how valid is this? But the other way of tracking is wastewater. And so you read the articles now about wastewater testing, which is a prospective indicator of things to come a couple weeks down the road, and they see that starting to climb now. So we can probably expect this to go back up, I guess.
Yeah, sewage water is a great surrogate, and you're right about that. It predicts the virus for the next surge. Not only can they tell the numbers go up, but they can also test it for which variant is that. So, I think we're just going to see it for a while. But fortunately, it's a low virulence, a lot of ambulatory cases. But I think that our primary care doctors are still getting just hammered with the number of appointments and the number of requests from patients.
Yeah. Keep your seatbelt on. Let's talk about treatment. So it's really on the high level, is there anything new in treatment?
No, nothing new so far. Okay. There is something coming down the pipe in research that looks really good, but so far the treatments are Paxlovid is the mainstay. There's still a lot of molnupiravir, so I listed this for everyone. Remember that molnupiravir is less efficacious than Paxlovid, but doesn't have all the drug interactions. Paxlovid, a ton of drug interactions. Molnupiravir, you don't want to use in pregnancy. Bebtelovimab is the monoclonal antibody. In our area, we're actually reserving that for the ED. So we use a lot of that in the emergency department. For patients who come in with COVID, they're sick enough, they have high-risk situations, but they're going to go home. So patients not requiring oxygen. So these are the ambulatory treatments available. I got a couple of questions from docs, and one of them was from Glency, and another one was from Carolyn Hellings. Really good questions. What do I do if someone tests asymptomatically and they have no symptoms at all? So I'm going to go to a wedding and I test myself. I'm asymptomatic, but I'm in a high-risk situation. So people who are asymptomatic with no symptoms don't need to be treated, even if they're in high-risk groups. And the other one for that is there's no indication for treatment of non-high risk groups. So 25-year-old has a mild cold, they test positive, it's COVID, goes to the family, there's no reason to treat them as well. And there's a couple thoughts there. One is that if we keep treating everyone, we're going to see viral resistance. It's inevitable. So we haven't seen it yet because we're not measuring it. But pretty soon we're going to probably see data showing that in certain instances of non-compliance and over-treatment, we're going to become resistant to molnupiravir and Paxlovid.
So that's just like treating viral infections with an antibiotic. Eventually you're going to get resistance to bugs and the antibiotics become less effective, same as Paxlovid.
That's very true. And also there's some new data that shows in the non-high risk patients, it doesn't make a difference. It doesn't prevent hospitalization, it doesn't prevent death, because the risk of hospitalization and death is so low in those populations. The Omicron strain is so less virulent, not as dangerous, that people in low risk settings are likely not going to be problematic. The only caveat I would say is if someone's 24, 34, and they're not vaccinated, that might be different. But,
so that'd be the one indication is potentially non-vaccinated. So in that nugget, in what you just said is the nugget that our docs need to know when people are calling, asking for Paxlovid, because I think sometimes the tendency is, there's no harm, let's just do it just in case. But the data that we have to support you declining treating them is that it's just not effective.
Right, it's not effective.
It's not going to help them at all.
And it's going to select resistance. It'll be unusable,
so we
kind of like the
information.
antigen was for the flu. So now, the only indication is high risk to progression of severe disease in a symptomatic person. And this is the third slide I'm going to show you is exactly from the CDC website, updated on June 15th. These are the high risk groups. And I bolded age over 65 and the unvaccinated. That's been the one who's really been the most problematic with severe disease. And then I listed all of these, and I tried to rearrange them a little bit into certain areas like lung disease, trying to list all those together. Immunosuppressed ones, like to list all those together. And if you want a copy of this, I'm happy to send it out to the group. If this helps you next to your desk, if you want to print it.
Yeah. Has this changed considerably over the last few months?
No, I think I printed this
just a reminder.
a few months ago. This is exactly the same information.
Yeah.
And we just kind of fell off our radar, I think, a little bit.
Sure. You know, one other new thing that has popped up is recently the FDA allowed pharmacists to prescribe Paxlovid to patients with a positive COVID test. And I actually went to the FDA's website to see what they actually said about that. And first of all, a pharmacy needs to opt in. And so I don't know how we're going to find out who's opted in, but I can imagine some pharmacies, perhaps the big chains, or maybe not, would choose not to opt in because I think it could be a lot of work for them. But you know, you have to look at what's required under this. So for instance, what's a requirement for the pharmacist before they can consider treating is they have to have an electronic, and this is right from the FDA guidelines, they have to have an electronic or printed health records no less than 12 months old, and including most recent labs, which must include renal and liver function. And they also must have a list of all medications the patient is taking in addition to over-the-counter medications. And it said the patient needs to have this. It says, or you like this, or the state licensed pharmacist could also consult with the patient's healthcare provider. So that's a phone call, so that's not particularly helpful. So what happens if, they have very clear, what happens if the patient doesn't bring in sufficient information, or if they detect that they would need to modify some of their existing medications?
Let me guess. Call your primary.
That's it. Go see your doctor.
Right.
So certainly not a panacea for treating the masses out there. I don't know how many pharmacies will adopt this, but I could just see the patients contacting us to get their records, get this and that, and we have to decide what you want to do with that within your offices. But you might want to just take over.
So Carrie, if this requires a lot of telephone stuff, you know, I think Jennifer Williams showed last night on the all-group meeting that there's a mechanism for docs to be compensated for that, to get RVUs for that. So
I think this is the perfect indication, because lots of times you're going to receive an email about this. Remember, you can return an email with a phone call and bill for that. Doesn't matter how the patient contacted us. And this is a perfect indication where you get an email, but you really have to dialogue with the patient to find out at least how they're doing, and get some of the specifics. And you're really doing a clinical encounter, and you know, we're treating people over the phone. You know, if they don't sound like they're doing well, of course we're going to have them come in. But this is a perfect example where you can use that telephone encounter And there's reasonable work RVUs to be obtained for your work, so you don't have to feel like you're being taken advantage of in order to provide what is excellent healthcare. So
Yeah, it's a perfect pilot.
we're just about to send out all the information. We went over this at the all-group meeting Jennifer did last night. We're going to be sending out more information on the kind of how to do that for everybody. So let's skip from that to the next raging pandemic that's taken over the world, which is monkeypox.
Yeah.
So it's being billed as such by the media, but what's the reality of monkeypox?
So it's crazy. I mean, when is this going to end? You know, if it's not, you know, the war in Ukraine, the fires in Europe,
Yeah.
monkeypox. So it's interesting. So this is this comes from the CDC website. This is as of July 19th. In the U.S., there are 2,100 cases confirmed. About a quarter of those cases are in New York City.
Yeah.
In California, we have 267 confirmed cases. We're going to see more. Sonoma County, the last I heard about a week ago, we had 3 confirmed cases in Sonoma County. Almost exclusively, these cases are on gay and bisexual men, and it's rare in women. I think when we got to 1,000 cases, there were 3 in women. You know, so it's incredibly rare in women. It has an atypical presentation. So the classic presentation in Africa of monkeypox, in West Africa or in the Congo, was a flu-like illness, and then 7 days later, pox lesions everywhere. This one has an atypical presentation, so there's something different with the virus. With this DNA virus, it seems to have a very mild or no flu-like prodrome at all. When people have that flu-like syndrome, they're oftentimes contagious from a respiratory droplet perspective, but we're not seeing that at all with this. And then when they do present, they don't present with body-wide lesions, they present with only a few lesions, and most of the lesions are genital. The lesions are painful, and they go from the classic tiny pimple, papule, pustule, and then it crusts and umbilicates. So that hasn't changed. It's remarkably uncomfortable, and so patients have developed, you know, difficulty urinating, difficulty with bathroom because of the pain where the lesions are.
Just to clarify one thing you said, so you said that the aerosolized transmission, we're not seeing that.
Yeah, no, so far we're
not. Contact
Right.
exposure.
It's a contact exposure. It seems to be 99% is skin-to-skin contact, even with a small papule, but it's not like a flu. It's not like COVID, where it's become respiratory.
So being in the room with somebody
Right.
is not putting you at risk at all.
Yeah, that's right. And the
Just
the task force that I work with Elaine on, the SBMF Infection Prevention Task Force, that was designed for COVID stuff. Right now, we're working on monkeypox KDSs. In other words, what kind of PPE do you need? How do you clean the room afterwards? And what's the precautions you need to take? So that'll be coming out in the very near future.
Okay.
Right. I wanted to talk about a few things, like what about vaccine? So vaccine is going to be very important for this. The vaccine is called Jynneos, Jynneos. It also goes by a couple other names in Europe. There's a very limited supply of this in the US right now, and all of it is coming through the public health department. So the federal government is buying vaccine, it's going through the state and health departments, and so we can't just buy it from a pharmaceutical company yet. It's a live virus, but it does not replicate efficiently in human cells, so it's actually safe in pregnancy and safe in immunosuppressed patients. It's only approved for 18 years of age or older. It's 2 subcutaneous doses that are 4 weeks apart. There is some severe allergies if you're allergic to gent, Cipro, or egg protein. So you need to know that before you get the vaccine. And currently at the health department, it's only being used for post-exposure prophylaxis. So post-exposure prophylaxis, 4 to 14 days after exposure to a known confirmed case, or with multiple sexual partners in an outbreak jurisdiction, for example, like what's happening in San Francisco and what's happening in New York City.
Okay.
But the public health department is directing that. Pretty soon we're going to have vaccine, probably within a month. We're going to have enough for pre-exposure prophylaxis. I'm getting a tremendous amount of requests from that in my clinic, especially in the PrEP patients that I see and the HIV patients. And I'm being very careful and clear to patients that it's not available yet unless you're a contact of a person. There is another live vaccinia vaccine that's used for monkeypox, but it has an enormous amount of safety issues. I just put the name there so everyone would see that, yeah, there is another vaccine, but with the safety issues, we probably will not be using much of any of that right now.
So looking forward, the details haven't been worked out, but what you're anticipating is when we do get a supply, the indications would be clearly post-exposure,
Right.
And then, but you're saying for high-risk groups, pre-exposure prophylaxis.
Right, for high-risk groups, it really is gay and bisexual men that have these wide sexual networks, social sexual networks, a lot of anonymous sex, someone going to a rave party. That's where this started. And I think it was in Belgium as well as in Portugal. It started from 2 different rave parties in Europe. So if there's going to be a lot of physical contact in that setting, then those are tremendously at-risk situations, and I would probably reach out to those patients and vaccinate them. Now, the other part, Gary, is that when we get vaccine, we're going to have to figure out where do we get it, how do we give it, does it come through public health, does it come through the hospital, do you need to freeze it? There's all those little operational details we done with COVID, and so that's in time to come. We'll be able to figure out how do we deal with the whole vaccine supply chain.
So that's the mechanics. The educational component when the patients are getting us is that it's going to be very limited indications, so potentially not even females, or not in general not females, but a very narrow population will be the ones who will receive the vaccine.
Right, so let me show you what I made a slide of this, and this is exactly the message I've been giving patients, and this is the last thing I'm going to present. The message I've been giving to patients is the public health department is supplying the monkeypox vaccine called Jynneos. It's a very limited supply of vaccine at this time. Therefore, it's currently being used only in patients exposed to confirmed cases or involved in intimate and/or sexual activity with multiple partners in outbreak locations. That's directly from the CDC website. The outbreak started and continues to involve predominantly gay and bisexual men, but has not yet involved other populations or activities. So, for example, we're not seeing this at other concerts. We're not seeing this in rugby teams, wrestling teams. We're not seeing this in spring break yet, in college scenarios. So, and then the other thing I tell patients that the CDC and the FDA are working on manufacturing more vaccine, projected to be available in the upcoming weeks to months. So that means that things may change. We may be more liberal with vaccine once we get enough.
So, people are talking about this as an epidemic, worldwide kind of thing, but we can predict now that we as healthcare providers should not allow this to rise to the level of concern for the whole population. We need to educate people and keep it narrowed to the affected population and kind of prevent some of the hysteria that could.
Yeah, that's important because I'm getting a lot of questions from patients who are not in the gay bisexual community, and they're really nervous about it because the news and the CDC has been a little bit ambiguous about this because they don't want to profile the gay community. So right now, I've been telling patients this is not the next COVID pandemic. There's been some hospitalizations because of pain and secondary bacterial infections, but there's been no serious hospitalizations. There's been no deaths with this outbreak outside of Africa. And this is going to be a contact infection, not a respiratory infection. So this is going to be a dermatologic issue. It's not going to be the next pandemic. And when I tell patients that, it's a relief, whether they're gay, bisexual, or not gay, straight, with other, or not sexually active at all, they're not worried about it. Because I think people with a lot of medical conditions, people who are frail and elderly, people who are immunosuppressed, they don't know what the contagiousness is of this. And they're really worried because they've been so heightened in the COVID pandemic that a lot of medical problems are dangerous with COVID. It doesn't mean that's going to be a problem with monkeypox. So the message is very different.
One other thing I want to point out, and you should be the one would like us to hear this, because previously we said monkeypox, if we have concerns, call you. Now we have the ability to test in the office, or to collect a specimen in the office. So those KDSs have gone out. You can collect specimens, send them to the Sutter lab, who will then forward on to Quest. And so we don't need to get you involved, the public health department. We can test if we have a suspicious lesion.
Thank goodness. That only happened because you came back from Europe.
Yeah, right.
Yeah, but it's LabQuest and LabCorp and Quest are now testing for this. It's also built in Epic now, so which is great.
Yeah. And I did clarify with the lab, Quest is our default lab. So if you just default to Sutter Lab, you don't have to decide where to send it. They will automatically send it to Quest because that's their the lab that they routinely use for outsourcing.
I personally have not seen a case yet, but I think we will eventually.
Okay. Great. I hope that was useful for everybody. Have a good rest of the week.